Olá, bem-vindos à quarta edição do Breastmit, o simpósio de tratamento minimamente invasivo e diagnóstico precoce com os métodos de imagem associados do câncer de mama. Essa é uma iniciativa da Sociedade Brasileira de Mastologia, da Sociedade Brasileira de Mastologia Regional Minas Gerais e da Escola Brasileira de Mastologia. Gostaríamos de agradecer os patrocinadores e apoiadores, em especial os patrocinadores Ouro, a BD e a Roche, os patrocinadores Prata, a Gerber, a AstraZeneca e a Siemens, e os patrocinadores Bronze, o Hospital Vila da Serra, OC Mulher, Metaltronic e CRX. Também a nossa cooperativa, que tanto nos ajuda a viabilizar os eventos, a Cicobi e a Credicom. Nessa sessão, inicialmente, eu queria convidar o presidente da Escola Brasileira de Mastologia, Dr. Guilherme Novita, médico do Grupo Oncoclínicas, para abrir esse simpósio, e o Dr. Valdeir Almeida, que é coordenador e chefe da cirurgia de mama, da mastologia, do Hospital Mater Dei, Belo Horizonte. Sejam bem-vindos.
Bom dia, é uma honra, é um prazer estar aqui com vocês. Eu queria parabenizar pessoalmente duas pessoas. A Bárbara Pace, presidente da Regional, por estar organizando novamente o Breastmit, um evento que hoje já faz parte do nosso calendário, mas eu tenho que parabenizar principalmente o pai da criança, que é o meu amigo Henrique. O Henrique, a gente tem alguns embates, porque eu acho que o Henrique é a pessoa, talvez, no mundo mais apaixonada e mais empolgada com todas essas questões de modernidade, de procedimentos minimamente invasivos. E ele, com certeza, está fazendo o Brasil chegar numa vanguarda disso. Henrique, parabéns, isso é um mérito teu e muito obrigado por estar aqui. A Escola Brasileira de Mastologia tem uma honra muito grande de participar com você do evento. Então, para vocês que vão assistir, bom evento e muito aprendizado.
Agora, passar a iniciação ao início da mesa, a palavra ao Dr. Valdeir, ex-presidente da Regional Minas Gerais, membro da Sociedade Brasileira de Mastologia e na sua diretoria, e vai coordenar essa mesa. Valdeir?
Bom dia, é um prazer estar aqui com vocês. Realmente é um excelente evento que a gente vai ter, eu tenho certeza disso. Todas as petições para o sucesso total. Parabéns, Henrique. Parabéns, Novita, pela Escola Brasileira de Mastologia. Parabéns, doutor Tufi, né, na sua gestão agora na Sociedade Brasileira. E parabéns, doutora Bárbara Pace, como presidente da Sociedade Brasileira de Mastologia Regional Minas Gerais. O Henrique consegue fazer uma coisa que poucas pessoas conseguem, porque esse evento é um evento sensacional, com quase 1.000 pessoas sendo online. Parabéns, Henrique. Bem, nós vamos começar agora a nossa mesa sobre imagens da mama, e eu quero apresentar as pessoas que vão me dão a honra aqui de fazer suas palestras. Doutora Alana Lewin, que é professora assistente de radiologia da seção de imagem de mama da Escola de Medicina da New York University, Grossman, diretor do programa de Fellowship de Imagem da Mama da New York University. Doutora Stamatia Destounis, radiologista de mama com expertise em imagem de mama e para triagem e diagnóstico, presidente da comissão de mama da American College of Radiology, sócia-gerente, diretor de pesquisa clínica e resultados médicos no Elizabeth Wendy Breast Care. Dr. Henrique Lima Couto, coordenador do Departamento de Imagem da Sociedade Brasileira de Mastologia, membro da Comissão Nacional de Mastologia, diretor-presidente da clínica Rede Mama. Eu quero também apresentar os nossos debatedores, o Dr. Giuliano Tosello, diretor da Sociedade Brasileira Regional São Paulo, presidente de mastologia, desculpa, diretor do Instituto do Câncer Radiológico Paulista, professor de medicina da Unieste, Presidente Prudente. A doutora Linei Urban, médica radiologista, responsável pelo setor de imagem da clínica DAP, Curitiba, Paraná, membro da diretoria do Colégio Brasileiro de Radiologia e Diagnóstico por Imagem, CBR, vice-presidente da Sociedade de Radiologia do Paraná. Doutora Sandra Campos Teixeira, radiologista, especialista em imagem e intervenção mamária, mestre e doutorando em oncologia ginecológica e mamária pela Faculdade de Ciências Médicas da Unicamp, membro da Comissão de Imaginologia Mamária da FEBRAB. Bem, nós vamos ter as aulas agora, né? Vamos iniciar, e no final a gente vai ter um debate. Eu tenho certeza que vai ser uma luta muito produtiva. Vamos começar, então, com as nossas aulas.
So today's lecture is entitled Breast Cancer Screening with Digital Breast Tomosynthesis. The objectives of this talk are to understand the strengths and limitations of screening, digital breast tomosynthesis interpretation, to review the effect of age and breast density on DBT interpretation, and to highlight the data on interval cancers and cancer subtypes detected with DBT. So DBT has been rapidly disseminated in the United States due to the consumer confidence and demand. According to MQSA national statistics, as of October 2023, about 88% of all certified breast imaging facilities and about 47% of all accredited mammography units in the US have DBT capability. However, worldwide adoption of DBT has been relatively slow, as cost effectiveness remains a concern, particularly in parts of the world where resources are limited. So compared to conventional 2D mammography, DBT images are acquired by an X-ray tube moved along an arc. Low-dose projection images are collected and reconstructed to 1 millimeter thick slices. Tomosynthesis is a technique that enables pseudotomographic imaging by acquiring a limited number of projections from a narrow angular range and combining these projections to reconstruct a quasi-3D image. The source projection images undergo a reconstruction algorithm generating the tomo slices, from which the synthetic 2D images are generated. So what is synthetic mammography? Well, it is 2D reconstruction of tomosynthesis projection images. It aspires to emulate a 2D mammogram, and the FDA approved its use for diagnosis in 2013. By replacing digital mammography plus DBT with synthetic mammography plus DBT, this can lead to an overall dose reduction of about 40%. So synthetic mammography can be used instead of full field digital mammography to both decrease the radiation dose as well as to reduce a small amount of acquisition time. So here's an example of a spiculated mass that's better seen on the synthesized views on the right, as DBT is known to accentuate the appearance of architectural distortion. So what about calcifications on DBT and synthetic mammography? Well, reconstruction algorithms use a high-pass filter that accentuates high-frequency spatial changes on an image. So this is bright spots such as calcifications. A phantom study demonstrated that synthetic mammography has a lower high-contrast spatial resolution compared to full-field digital mammography, with loss of detection of small calcifications, but improved detection of large calcifications. And multiple subsequent studies of synthetic mammography and DBT, including reader studies and studies in clinical practice, have showed that synthetic mammography plus DBT is non-inferior to full-field digital mammography and adequate as a replacement for evaluating calcifications. So here's an example of calcifications that are better seen on the synthesized 2D view on the right compared to the full-field digital mammography view on the left. So since synthetic mammography uses a high-pass filter and reconstruction algorithm to enhance calcifications, this can falsely enhance quantum or structural noise, such as seen with Cooper's ligaments. So if calcifications are seen only on synthetic mammography, but not on digital mammography or DBT images, then these are termed pseudocalcifications. So in this case, there were question group calcifications in the central left breast posterior depth seen on the synthetic mammographic views. And here's just a zoomed in image showing that. This was not seen on the full field digital mammography views. So it's recommended for additional views, and you can see here that there are no corresponding abnormal calcifications on the magnification view on the left here, and this original finding was deemed artifactual. So the benefits of screening with digital breast tomosynthesis compared to digital mammography have been demonstrated in multiple studies, including reduced recall rate and improved cancer detection rate. In this review from 2021, the reduction of recall rate with DBT ranged from 15 to 37%, and the improvement in cancer detection rate ranged from 15 to 53%. This is a recent retrospective study published in Radiology this year, which investigated approximately 2.5 million screening mammograms performed in 1.2 million women from 2014 to 2020. Data was collected from a multi-institutional United States database. DBT was compared to digital mammography and showed a significant reduction in the recall rate, an increase in the cancer detection rate, an increase in PPV1, an increase in biopsy rate. And these results were consistent with prior studies. So the conclusion of this study is that women undergoing DBT had improved screening mammography outcomes compared with women who underwent digital mammography. So here's an example of a spiculated mass in the central right breast middle depth that was seen only on the DBT images. You can see here that the corresponding full field digital mammography views to the left of the DBT images, the finding just looks like normal fibroglandular tissue. And this underwent core biopsy yielding invasive ductal carcinoma. Here's another example of improvement in cancer detection rate with DBT. You can see here in the superior left breast, there is a relatively stable, small mass that was seen on the 2D images that was thought to be a lymph node as it was next to a corresponding vessel. However, on the tomo slices, it appears to be a spiculated mass, as you can see here on this zoomed in image. This was confirmed on additional views, as you can see here. And then on the ultrasound, there is a corresponding sub-centimeter spiculated mass at left 10 o'clock. And this was consistent with a well-differentiated invasive ductal carcinoma. Here is an example of how tomosynthesis images can reduce the recall rate. So on 2D, there is an asymmetry in the superior right breast. But upon scrolling through the DBT slices, you can see that it is overlapping fibroglandular tissue and it does not need to be recalled. Similarly, in this case, the asymmetry in the lateral right breast posterior depth is actually just superimposed Cooper's ligaments. So now that we've reviewed some of the benefits of DBT, we need to ask ourselves, do outcomes differ when comparing the first or the prevalent screening round to subsequent screening rounds? And limited and mixed data exists on the rate of screening detected cancers found at various screening rounds after DBT. A study from 2020 showed that the largest improvements in recall rate and cancer detection rates with DBT were seen on baseline screens. A subsequent study, a European randomized control study in 2021, found no difference in the rates of subsequent screening rounds with DBT screening. And an Italian randomized control study in 2022 showed that although DBT depicted 70% more cancers, the screen detected cancers at the following rounds were similar. The most recent study on this topic was published this year, and it's a large retrospective study that evaluated breast cancer screening outcomes with DBT versus digital mammography on successive screening rounds. The data was collected by 5 breast imaging registries within the Breast Cancer Surveillance Consortium. About 500,000 DBT and 1 million digital mammography screen exams were performed in 500,000 women across 58 breast imaging facilities. These results demonstrated no difference in the overall cancer detection rate observed between DBT and digital mammograms in screening round 1 or 2. But for screening round 3 and above, the cancer detection rate was significantly higher for DBT, including a significant difference in the rate of screen-detected early invasive cancers. So the conclusion of this study is that DBT helps to detect more cancers than digital mammography across 3 screening rounds, but with no difference in the interval or the advanced cancer rates. So all of this data calls into question who benefits most from screening with DBT and when screening with DBT is most effective. And the jury is still out at this point. So now we'll review the effect of age and breast density on DBT screening interpretation. So according to the 2023 revised ACR appropriateness criteria guidelines for female breast cancer screening, DBT screening recommendations are provided based on breast cancer risk, as you can see here. But how do age and breast density affect DBT interpretation? Well, initial studies showed that the benefits of DBT were present across all age and breast density groups. However, the results of more recent retrospective studies between 2017 and 2021 are mixed and have shown a superior cancer detection rate for younger women, so age 40 to 49, and in women with dense breasts. In addition, the cancer detection rates have been shown to be higher with DBT in all breast density categories except extremely dense breasts. And in this recent retrospective study from 2023, which we've previously discussed a bit earlier in the talk, 2.5 million screening mammograms performed, the cancer detection rates were higher with DBT in all breast density categories and across all ages. In 2022, the results of the largest screening randomized controlled trial to investigate the effect of DBT in synthetic mammography were published. The study, included nearly 100,000 women at 17 centers in Germany, and equal numbers of women were included in each arm of the study. So there was the DBT with the synthetic mammography arm and the digital mammography arm. The primary study outcome was invasive cancer detection rates between the two study arms. And the results show that the invasive cancer detection rate was 48% higher with DBT plus synthetic mammography compared to digital mammography alone. And this is a sub-analysis from the data of that same trial that was published in Radiology in 2023, in which invasive cancer detection rates were examined according to breast density. So in women with extremely dense breasts, the absolute difference in invasive cancer detection rate between the two arms was 5.8 per 1,000 screening exams, which corresponded to an odds ratio of 3.8. And when combining the dense categories, the DBT arm still detected an additional 2.7 invasive cancers per 1,000 exams. And so these findings suggest that women with extremely dense breasts could benefit most from DBT screening. So here's an example supporting the findings of that study. This is a routine screening mammogram in a woman with heterogeneously dense breasts. And you can see here that the 2D mammogram views appear normal. However, in the superior right breast, posterior depth, there's an area of architectural distortion seen only on the tomoslices, and this was consistent with invasive ductal carcinoma. So in the last few minutes, we'll review the data on interval cancers and cancer subtypes that are detected with DBT. So DBT accentuates the detection of masses and architectural distortion while decreasing the recall rate of asymmetries, which enhances both the sensitivity and specificity of cancer detection. DBT allows for the preferential detection of invasive cancers, including invasive ductal and invasive lobular cancers. And most studies have shown that these cancers are more indolent. But DBT has not been shown to increase the detection of in situ cancers. Mariscotti et al. Showed that this tomosynthesis has increased sensitivity and accuracy for invasive lobular cancer, detected as both architectural distortion and masses on imaging, with increased cancer detection rate of multifocal and multicentric contralateral disease. Subsequent additional studies have confirmed that invasive cancers detected on DBT tend to be smaller, of lower histologic grade, and less likely to be node positive at the time of detection. Invasive cancers detected with DBT only are more likely to be grade 1 tumors, luminal A subtype, and have low proliferative indices. So this is a case of a routine screening mammogram in a woman with heterogeneously dense breasts, and on the digital mammogram images, there's no suspicious abnormality. But on the DBT images, there is a spiculated mass at left 9 o'clock. This was occult on 2D, and this yielded invasive lobular cancer. So finally, we should ask ourselves, is there a mortality benefit of screening with DBT? And at this time, the answer to that question remains unknown. Without data from randomized controlled trials, the interval cancer rate serves as a surrogate marker of screening efficacy and an indirect indicator of mortality benefit. With the exception of the Malmo trial, none of the studies in Europe or in the US have shown a significant reduction in interval cancer rate with the use of DBT. However, the studies have been significantly underpowered, which has been a criticism of them. So what is needed to help us better understand the biologic profiles of DBT-detected breast cancers and their long-term outcomes? Well, two prospective trials are underway in North America and in the UK. The TEMS trial is a large randomized clinical trial comparing the effectiveness of screening with digital mammography versus DBT, and the Prospects trial in the UK will compare cost effectiveness and interval cancer rates of DBT plus digital mammography compared to digital mammography alone. So they're currently enrolling patients for these trials, and the results are to be determined. So in conclusion, DBT improves lesion conspicuity, allowing for improved detection, characterization, and localization of lesions. Screening mammography using DBT is replacing digital mammography as the preferred imaging modality in the United States, as studies have demonstrated lower recall rates and a higher cancer detection rate. This has occurred to a lesser degree in Europe. However, further studies are needed to make final conclusions regarding the long-term outcomes of DBT screening. Thank you.
Hello, I'm Stamatia Destounis, and I'm going to be discussing an update of the American College of Radiology recommendations on breast cancer screening. And thank you for the invitation. So breast cancer continues to be, as we know, the most common cancer diagnosis for women at 31%. This is from the American Cancer Society Facts and Figures data for 2023. It's also the second leading cause of cancer deaths after lung. If we look at the cases for invasive cancer in the United States in 2022, we're at 287,000 women. Ductal carcinoma in situ cases, over 51,400, and deaths are at 43,250. So for breast cancer screening, we have many studies over many decades showing us a reduced mortality from breast cancer of about 30%, according to the randomized control trials that we have seen over the years, and as much as 48 to 50% by observational studies. The optimal screening protocol, however, has been heavily debated by many groups and societies, and when to start screening, when to stop, and at what interval. And up to now, what we've had is predominantly population-based screening and not personalized and a risk-based kind of decision for each patient. We know the benefits of mammographic screening are there, and that's independent of whether we're looking for the longest survival. It's meaningful to have a diagnosis of breast cancer at an early stage, and these tumors are smaller, the lymph nodes are negative, so the treatment for the patient and also any comorbidity after the treatment will be less. It's important also to find these high-risk lesions that allow the patient then to have personalized type of care and chemoprevention or ancillary screening with MRI and surveillance that is, catered to that patient so we can find these malignancies that may be difficult to find. And we want to avoid compromising the quality of care of the patient because we don't want to find advanced disease. We want to find it early. So when the prognosis is so good, really, the 5-year relative survival rates here by many studies show that for stage 1 and stage 2, the survival rate is very good. As we get into stage 3 and 4, obviously the survival rate drops, quickly. So we want to find these cancers early and small. When we look at the randomized control trials that evaluated mammography screening, and I'm looking at all the trials and really discounting the Canadian studies because over the years they've been debunked for many reasons. The methodology, randomization, so many issues with their technology and really how things were done. But the other study showed us a significant reduction in breast cancer deaths of 15 to 30%. For the women that were invited to screen ages 40 to 74, and really significant mortality reduction for young women, the women in their 40s, when they were invited of 15 to 18%. You can see the follow-up of most of these studies expand, from 10 to 20 years, and they were done some in the 60s, some 70s and 80s. So we're talking many decades of data, and the study duration for these studies were also different. But looking at the incidence of breast cancer, and when we look mortality by race, we know the breast cancer incidence is highest amongst white women. That's at 133.7 per 100,000, according to the American Breast Cancer Statistics for this past year. But the mortality rates are the highest amongst Black women, as much as 40% higher than white women. And this disparity really is likely because these women may be diagnosed at a later stage, may have more aggressive cancers with the triple negatives, but also experience delays in their treatment after their diagnosis and may have less access to high quality treatment and care. And when we look at the stage of diagnosis by race, and we look at this graph from the American Cancer Society, we see that white women are more likely to have localized disease. The same is for Asian Pacific Islander women. But when you look at Black, Hispanics, and American Indian and Alaska Natives, they're much more likely to have less localized disease and more likely to have regional or distant metastases. So this really does speak to lack of access to care or, unequal access to care that occurs, in addition to the risk that they may have more aggressive disease. So the American College of Radiology has breast cancer screening recommendations that were inclusive of all women at average risk. And this is an update from the Society of Breast Imaging and the American College of Radiology. And so this was published in 2021 in a journal of American College of Radiology. And what we say in this, and I'm one of the authors, that annual screening mammography for all women, inclusive of all women 40 and over, we do discuss about the mortality reduction is significant for women, and breast cancer deaths, are significant for when women start to screen at 40, and it provides the greatest mortality reduction, but also the best, diagnosis for smaller size, better surgical options, less chemotherapy. We also do not tell women to stop screening at age 75 because if they're of good health, we don't have an upper limit on when to stop. When we find these smaller tumors by screening women at yearly intervals, we have the greatest opportunity to really find them the smallest possible when the patients do the best. So this is kind of a poster representation of the same thing. At that time, we recommended that every woman have a risk assessment by age 30, and then annual mammography starting at 40, no upper limit, but also to discuss with their healthcare provider the possibility of any risks and where the benefits, of course, outweigh the risk with recalls, benign biopsies, and anxiety. So we, both the ACR and SBI, discussed weighing the benefits and the risks of mammography for that should be done by women and not for women. Now, for the women that were at higher than average risk, we updated these recommendations from the American College of Radiology just this past May 2023, and we published this in the Journal of, American College of Radiology. And so we changed our recommendations a little bit. Now we recommend that all women should undergo a risk assessment by age 25, especially Black women and women that are Ashkenazi Jewish descent. And that high-risk women should be screened with mammography and MRI. So, of course, it's important for the high-risk women to be able to have supplemental screening with MRI. If they are unable to have MRI, then contrast-enhanced mammography can be considered. So that was an addition that we had. We actually explained what we consider, who we consider to be the women at high risk, women that have a calculated lifetime breast cancer risk of 20% or more. They should undergo digital mammogram with or without tomosynthesis. They should start annual MRIs between 25 to 30. Women that are mutation carriers, if they've had radiation treatment to the chest wall. So we explain when they should start screening with mammography and or tomosynthesis and also MRI. And especially for women that have a personal history of breast cancer and may have been diagnosed at less than 50 years old and also underwent, have dense breasts, they should also undergo supplemental screening with MRI. So we do discuss that. We discuss women with dense breasts. And if they do want to have a supplemental study, we recommend breast MRI. If they had atypia or lobular carcinoma in situ, you should consider supplemental surveillance with MRI also. So this is kind of a table of where we discuss the women that we consider higher risk, the changes from our prior recommendation for the women at high risk for the ACR to the current recommendations in 2023. And basically what we have changed a little bit here, and it's kind of included in the darker color, for the more updated recommendations to consider abdominal radiation treatment that overlaps the breast in the risk. Also to consider for the dense breast tissue, annual MRI, and consider contrast enhanced mammography or ultrasound as an alternative if they cannot have MRI. And for all women to now have a risk evaluation, a risk assessment by age 25 instead of age 30. And most of the recommendations have not changed significantly, but there were some changes for 2023. You know, for the higher than average risk population, obviously there are multiple factors that increase the risk, and genetic mutation is there. And we have the table for what the actionable genetic mutations are for higher risk for breast cancer. We have BRCA, obviously. We have the CHEK2, PLB2, as you can see, PTEN, TP53. So those are significant lifetime increase for breast cancer risk from 20 to greater than 60%, as you can see on that table. African-American women, those of Ashkenazi Jewish descent, they may be at the higher risk for BRCA mutations. And of course, we want to make sure that we identify them. If there's a strong family history, like I mentioned already, chest wall radiation, personal history of breast cancer, or the high-risk lesions, high breast density, race, and ethnicity all play a role. Breast MRI has been very important as a screening tool. Many studies have shown that it has very high sensitivity, more than mammography and ultrasound, or the combination of both of those exams. The sensitivities are reported to be quite high and also high specificity, with cancer detection rates of 7 to 20 per 1,000. And we, of course, acknowledge that, and we realize that by doing MRI, many studies are showing that we're shifting earlier disease diagnosis and fewer interval breast cancers by doing supplemental MRI, and the benefits are seen in many higher than average risk and also average risk populations. So by starting an annual MRI at 30 to 35, and we can follow biannual MRI mammography at 40, we may be reducing the breast cancer mortality by more than 50%. Many studies show for women that have these genetic mutations, such as ATM, CHEK2, and PLB2. And amongst the BRCA carriers, annual screening MRI has led to a large reduction for incidence of advanced stage breast cancer and also node-positive disease. And we want to certainly identify those BRCA carriers, because the ones that undergo MRI, they've had improved 10-year survival, and the cancers are less than a centimeter, we're finding from many articles that have been published as of late. So for the personal history patients, we've had many retrospective studies that show significant sensitivity of MRI compared with mammography. And these studies show that the sensitivity and specificity with the personal history can be quite high. And so it's significant for these women that have been diagnosed at or age before age 50 and have a personal history of breast cancer and may have dense breasts to recommend supplemental MRI along with their standard screening, which may involve a digital mammogram or a tomosynthesis study. So of course, we still have a lot of work to continue doing to see what other subsets of women with personal history may benefit from MRI screening. Now, MRI has, for the high risk now, what about the personal history of a lobular carcinoma in situ or other atypia? Well, we have some good work that's been done that shows that there's a higher cancer detection for these high-risk populations because of atypia. And some studies like SIPO shows a cancer detection rate of 15 per 1,000 when you have a history of high-risk lesion. So these women also may have additional risk factors, dense breast, they may have had a personal history of breast cancer, family history. So although we don't have a lot of data on this, the current evidence shows that, MRI may be helpful. How about the women with extremely dense breasts? The dense randomized controlled trial that showed in the prevalent round for MRI screening 16.5 per 1,000 cancers and a 50% reduction in interval cancer rate, suggesting a real mortality benefit. So this was, very important. The second round for cancer detection rate for this study was 5.8 per 1,000, but the false positive rate drops substantially. So that's also very important. So for women that have average or intermediate risk for dense breast, and they have dense breast tissue, and they may not be at high risk for any other criteria, MRI really is the best supplemental imaging tool, studies are telling us, with far better cancer detection and favorable PPVs. What about some alternative screening modalities? Well, contrast-enhanced mammography could be considered as a potential supplemental screening tool if the women have dense breasts or other factors that may put them at that higher risk category but are unable to have an MRI. So for MBI, we don't recommend MBI in the latest ACR recommendations for the higher than average risk women. So we don't recommend it as a supplemental screening tool. Ultrasound should be considered for these women if they're unable to have MRI and are unable to have contrast-enhanced mammography. Certainly, we know that ultrasound is finding additional cancers over tomosynthesis in women with dense breasts, but we have to weigh the benefits and the risks because we will be getting into some false positive biopsies. So in summary, annual mammography screening starting at age 40 is what we recommend for all women that are average risk or higher than average risk. But we need to do risk assessment evaluation for patients by age 25 for all women, especially the ones of Ashkenazi Jewish descent or Blacks. And if the women have genetic mutations or higher than 20% calculate lifetime breast cancer risk, you undergo annual mammography by age 30, annual MRI, you want to start between 25 to 30. If women have had chest wall radiation, you want to start with annual mammography at 25 or 8 years after radiation treatment, whichever is later, annual MRI starting at 25 to 30. Women with a personal history of breast cancer and they're at younger than 50 and with dense breast, annual screening MRI. Women with dense breasts or personal history of atypia or lobular carcinoma in situ consider supplemental MRI yearly. And my references and my email, and I want to thank you for your time.
Olá, como vão? Antes de mais nada, é um prazer estar aqui para falar um pouco sobre as recomendações da Comissão Nacional de Mamografia para o rastreamento do câncer de mama no Brasil. Eu não tenho conflito de interesse para essa apresentação. Essas são as minhas atividades profissionais e representativas. O câncer de mama é o câncer mais comum entre as mulheres. É a principal causa de câncer, de morte por câncer nas mulheres no mundo. Também no Brasil. A estimativa de 73 mil casos novos para 2023, com uma incidência de 41,89 por 100 mil. O interessante é a comparação com os países desenvolvidos, em que a mortalidade do câncer de mama começa a cair durante os anos 90, e a nossa parece que começa a cair agora nos anos 2020. Uma defasagem de lei de 30 anos. A redução da mortalidade é consequência do diagnóstico precoce associado a modernas terapias sistêmicas. Estima-se que seja 1/3 de diagnóstico precoce, 2/3 de terapia sistêmica, mas isso não é bem verdade, porque você só consegue fazer a redução em estágios precoces com terapia sistêmica se você faz o diagnóstico precoce. Então, o impacto do diagnóstico precoce é muito importante na redução da mortalidade. E o rastreamento no Brasil, ele é ruim. um bom programa de rastreamento organizado, a gente teria que ter 50% de carcinoma mínimo, 50% de cânceres com menos de 1 centímetro e com axila negativo. Não é o que ocorre no Brasil. Então, a metodologia nossa foi uma revisão sistemática de 2012 a 2022. Avaliamos os riscos de bias dos estudos. Fizemos uma primeira rodada de votação, que o consenso chegaria com 75%. Uma segunda rodada, que o consenso seria maioria simples. Dividimos as recomendações em A, forte a favor, B, forte a favor, com moderada qualidade, A, com alta qualidade, C, fraca a favor, com baixa qualidade, D, a favor, consenso de especialistas, e E, contra. Basicamente, a primeira coisa é reforçar que a mamografia deve ser feita anualmente a partir dos 40 anos. Isso segue as principais recomendações no mundo, como do Colégio Americano de Radiologistas, inclusive a US Task Force, que era uma grande crítica disso, passa a assumir mamografia a partir dos 40 anos. É importante notar que é uma verdade que a mamografia diminui a mortalidade por câncer de mama a partir dos 40 anos. E uma situação especial no Brasil é que em torno de 40% das mulheres com câncer de mama estão abaixo dos 50 anos. Então, não rastrear mulheres abaixo dos 50 anos é abandonar essa população à própria sorte. Não só é importante reduzir a mortalidade, como a mamografia, a partir dos 40 anos, reduz o localmente avançado, reduz os casos com axila positivo. E isso faz muita diferença. Em relação à tomossíntese, a novidade na nossa recomendação é que ela deve ser feita sempre que disponível. Tomossíntese é uma técnica que, ao fazer várias incidências, num ângulo de 15 a 60 graus, permite montar essa mama de uma maneira tridimensional, dirimindo ou resolvendo parcialmente ou totalmente a questão da sobreposição de estruturas. A tomossíntese hoje ela é recomendada pelo NCCI não como se disponível, mas como um método preferencial para o rastreamento de câncer de mama. Também ela já é recomendada pelo Colégio Americano de Cirurgiões de Mama. Inicialmente, achava-se que a tomossíntese aumentava só a detecção de cânceres menos invasivos. Hoje a gente sabe, por várias meta-análises, que ela detecta 40% mais câncer, ela aumenta a taxa de detecção em 40%. E tanto esse aumento de detecção é de carcinomas de baixo grau, como também de alto grau. É importante entender que existe uma crítica de que ainda não temos ensaios randomizados com tomossíntese que diminuem a mortalidade. Mas isso não é a questão. Ensaios randomizados que diminuem a mortalidade vão demorar até 20 anos para que a gente tenha esses dados. Então, a gente tem que recorrer a modelos econômicos de custo e eficácia para que a gente consiga incorporar essas tecnologias antes de aguardar 20, 30 anos de estudos randomizados. Então, quando a gente olha o tratamento do carcinoma de mama em estágio 1, ele é muito mais barato do que um tratamento em estágio localmente avançado ou metastático. Além disso, a tomossíntese reduz as taxas de reconvocação em exames adicionais e biópsias. A consequência disso é que provavelmente ela reduz os custos. Nós fizemos um estudo que demonstrou que numa análise probabilística multivariada, a tomossíntese com um limiar de intenção de pagar de 7 mil euros, que corresponde a 40 mil reais, que é o limiar do Brasil, ela foi 100% custo efetivo. Isso significa que ela levaria uma economia de uns 200 milhões de reais num bom sistema organizado. E esse dinheiro poderia ser investido em melhorar as taxas de cobertura, o rendimento do programa de rastreamento. De forma que foi submetido pelo CBR uma incorporação de tecnologia, nós apoiamos, tanto Febrasmo como Sociedade Brasileira de Mastologia, e agora aguardamos o resultado final dessa introdução da tecnologia. Bom, esse esforço intelectual todo é simplesmente para mostrar uma coisa óbvia. Uma mamografia digital uma tomossíntese no mesmo horário, na mesma hora, você vê o carcinoma muito mais simples. Tomografia digital normal, aqui na tomossíntese você vê o carcinoma. É uma coisa intuitiva, assistir televisão na casa da vovó, né, ou a preto e branco, se você assistir, você vai ver muito mais coisa, muito mais detalhe. A nossa recomendação nova traz avanços em relação às pacientes de risco intermediário, como, por exemplo, as de mama densa. Verdade é que existe o paradoxo do sobrevivente. A gente precisa achar os cânceres que nós não estamos vendo. E, para isso, nós recomendamos fazer ressonância magnética para as mamas densas, principalmente abaixo de 50 anos. Se a ressonância não está disponível, você vai fazer ultrassom. Qual é a grande diferença? É que a ressonância magnética parece ser custo-efetiva a cada 2 anos ou 4 anos, com uma redução em um diagnóstico de mortalidade e um diagnóstico excessivo a mais de 16 cânceres por mil. O ultrassom não vai te dar isso. O ultrassom vai te dar no máximo 4 cânceres por mil. As pacientes com risco intermediário, aplasia lobular atípica, carcinoma lobular in situ, devem ser submetidas, como todas as pacientes, como todas as mulheres, a avaliação em modelos de risco, para saber qual que é o risco delas desenvolverem câncer durante a vida e serem enquadradas num rastreamento personalizado. Essas pacientes com risco intermediário devem fazer uma ressonância magnética, principalmente se o risco delas for maior do que 20%. As mulheres que já tiveram câncer de mama devem ser seguidas com a mamografia e, eventualmente, com a ressonância magnética, principalmente se elas têm menos de 50 anos e mamas densas. Mulheres com radioterapia torácica são pacientes de alto risco. Elas devem começar a fazer ressonância magnética a partir do 8º ano pós-tratamento do tórax com radioterapia, não antes dos 25 anos. E a mamografia deve começar também nessa idade. Em relação às pacientes de alto risco, com história familiar maior do que 20%, ou mutações, a gente fez recomendações personalizadas. Atualmente, essas recomendações nossas são para pacientes com BRCA1, mamografia a partir dos 35 e ressonância a partir dos 25. Para mulheres com BRCA2, mamografia a partir dos 30 e ressonância a partir dos 30. Para mulheres com linfomania, TP53, mamografia a partir dos 30 e ressonância a partir dos 20 anos. Lembrar que precisamos mudar isso, ressonância não existe código no SUS, usa-se um código de ressonância torácica, isso não é a mesma coisa, isso precisa ser evoluído. E precisamos evoluir na personalização não somente do alto risco, mas também do baixo risco. 4% dos cânceres de mama acontece em 18% dos cânceres de mama, né, 20% praticamente, então 20% deles, dos cânceres de mama, acontecem em 4% das pacientes de alto risco. Em compensação, somente 4% dos cânceres de mama acontecem em 20% das de baixo risco, e essas pacientes estão fazendo mamografia sem necessidade. Então, a gente precisa também descalonar essas mulheres para que a gente tenha mais dinheiro para aplicar onde é de maior risco e vamos ter mais impacto. Chamar todos ao curso de procedimentos minimamente invasivos da Sociedade Brasileira de Mastologia, que nós vamos ter edição em 2024 agora, que vai ser lançado. Todos estão aqui conosco no Breastmit 2023 e esperamos todos também no Breastmit 2024. Um abraço a todos. Aguardo para o debate, que vai ser muito interessante.
E parabéns a todos pelas aulas, realmente foram aulas brilhantes. Muito obrigado pela disponibilidade, pelo tanto conhecimento que vocês nos passaram. Eu quero iniciar os debates, eu queria chamar a doutora Linei Urban, doutora Sandra Regina Campos Teixeira e doutor Giuliano Tosello, para a gente começar os debates. Por favor, abrir as telas. Bem-vindos. Linei, sua câmera está desligada. Bom, vamos começar com a Linei. Pronto, você chegou. Vamos começar, então. Sandra, Você pode começar com o debate, depois a gente passa para o Linei e depois trazer, por favor.
Bom dia a todos. Um prazer estar aqui. Agradeço o convite e excelente aulas, palestras. Queria começar perguntando para a doutora Alana em relação à tomossíntese. A gente quase não tem, foi tão brilhante a explicação. A minha dúvida, que na verdade é o que a gente mais vê de alguns debates, e até o doutor Copas, que publicou até recentemente, acho que no Radiology, a respeito disso, uma opinião da tomossíntese, que ela, se a gente deixar de fazer a mamografia digital, que estaríamos perdendo justamente as calcificações. A gente sabe que a tomossíntese tem, mesmo na sintetizada, ela pode perder um pouco nessa avaliação das calcificações, mas a dúvida é, talvez a gente não estivesse perdendo justamente as calcificações que poderiam ser aqueles in situ que talvez nunca se expressariam, aqueles de baixo grau, que a gente não tem como prever isso, né? Mas gostaria de saber qual que é a sua opinião a esse respeito.
Well, thank you for having me. I'm happy to be here. You know, there's a lot of debate in the literature about overdiagnosis with, sorry, there's echoing. Does everyone hear that? Do you hear the echoing?
No problem, go ahead.
Okay, sorry. There's a lot of debate in the literature about overdiagnosis with DCIS. And so, you know, perhaps DBT will help us. Yeah, I think someone's iPhone is on. Can you mute the iPhone? Oh, awesome. Thank you. So, you know, perhaps DBT with, you know, detecting, you know, being able to see fewer of those areas of calcifications will help us, you know, with that. But, you know, the studies have shown that it is, you know, appropriate for diagnosis, you know, not using digital mammography and focusing on tomosynthesis, that it helps us to detect, you know, the important cancers, the invasive cancers. And so, you know, I think that, you know, even from our experience here at NYU, you know, we're really not losing anything.
Okay, thank you. I agree with you. It's a huge advance to use the DBT. Sorry, speaking in English. É um grande avanço a gente usar a tomossíntese, quer dizer, deixar de usar, né, parece realmente ser um retrocesso, né? Em relação à próxima palestra, né, da doutora Stamatia, é isso? Correto? A pronúncia? Stamatia?
Stamatia Destounis.
Muito obrigada, excelente também explanação, e o que eu gostaria de saber é como que a gente pode levar com mais qualidade, talvez, a ressonância e a interpretação dos achados, que às vezes a gente não consegue reproduzir na mamografia e no ultrassom. Aqui no Brasil, a gente tem muita dificuldade para realizar a biópsia por ressonância, né? São poucos os centros que fazem. Eu faço biópsia por ressonância e sei a dificuldade, tanto às vezes das pacientes aceitarem ou dos convênios liberarem, e é caro para fazer particular. A ideia é que talvez como que a gente poderia melhorar esse acesso para toda a população? É uma pergunta difícil, mas queria a sua opinião.
Sandra, thank you. Of course, you gave me a very easy question to answer. This is a question I'm asked every time I speak internationally. There's no reimbursement. The biopsy devices for MRI are very expensive. There's no reimbursement for the clip. So there's just lots of issues, and I understand all of them. When we started our MRI practice, it was like in the year 2000. In my area, we were the first ones, and there was no reimbursement for it. In fact, they didn't want us to do it at all. So I had to go to the insurance companies for 5 years in a row, petitioning, bringing articles early on, our own work, what we found. So we started doing it, and we were insistent that we needed to be able to do MRI biopsy to do it. So I really think in the perfect world, if you're doing breast MRI, you're going to find things. That's the whole point. You're going to find 15 to 16 to 18 cancers per 1,000 in the right population, even in average risk women with dense breasts. So it really is a shame if we're doing breast MRI, and then of course we're not going to identify these subtle findings on ultrasound, or even the best tomosynthesis, as Dr. Lewin went through and told us. We're not going to find non-mass enhancement. We're going to need to do an MRI biopsy. So I think in the short term, you're going to have to build relationships with the few entities you have that do MRI biopsy, carve out time so they can have time on the magnet for MRI biopsies, because some facilities and institutions have MRIs, they just don't have any breast designated time. So, and you need to, build good relationship with the vendor companies that provide these biopsy devices for you, and argue for inexpensive pricing, minimal pricing, work with them collaboratively to do retrospective reviews of your own work, of what you're doing, publish it, and fight for it. You need to fight for it. It wasn't easy in the United States. I'm at a big private center in New York, in upstate New York. Reimbursement is very low. And basically, every time I went up to the insurance carriers asking for some reimbursement for it, they told me, if we let you do it, you're going to do it on everyone. You're going to do MRI on everyone. You're going to do too much MRI, So I had to keep going back and showing them that we're finding cancers. We're doing the right thing. And so we did not get paid for a while. We just kept doing it. And then we had enough data that they had to listen to us. And now everyone in our area is doing breast MRI. Everyone is doing MRI biopsy, but we led the way, and we did it many years ago. And you can do it too. And you're going to have to do it for free in some cases, and come up with really smart ways to do the clips, to find ways to do it, but don't give up, because I do think the vendors, the MRI vendors, the biopsy vendors, they want to help you because they want to promote their products. So you need to find those vendors that will work with you and really help you and be the champion for it in your area.
Muito obrigado.
Thank you a lot.
Eu queria chamar a doutora Linei Urban, por favor, para participar agora.
Bom dia a todos. Inicialmente, eu gostaria de agradecer esse convite. É um prazer e uma honra participar de um evento de tamanha vanguarda, acho que tanto no Brasil como no mundo, e que contribui tanto para o avanço do tratamento do câncer de mama. E parabenizar principalmente Henrique e toda a comissão organizadora. E foram excelentes apresentações. Nesse contexto, eu gostaria de iniciar perguntando para a doutora Alana. Doutora Alana, como está a realidade do rastreamento nos Estados Unidos com a tomossíntese? Qual é o percentual de pacientes que fazem o rastreamento com a tomossíntese? É uma escolha da paciente, é uma escolha do médico solicitante ou é uma escolha do programa de rastreamento? E no contexto do descalonamento, o uso da mamografia sintetizada já é uma realidade para substituir o combo?
They're all great questions. So, at academic centers, DVT is the standard of care. at a lot of smaller practices, across the country, they haven't sort of made the leap to DBT, although they are slowly doing it. At our practice at NYU, all patients get DBT. However, some patients do come very informed and ask, and say, I don't want the radiation from 3D, and we have to, discuss that with them. The benefits of DBT, that it's really not, additional radiation. And long term, when we're reducing recall rates, they'll ultimately have overall less radiation dose. So some patients do read up ahead and, ahead of their exams and come with informed questions. But for us, all patients, if they're presenting for, screening and diagnostic, mammography, they get DBT. We've just seen the benefits of it. Unfortunately, our institution, we have not made the leap from digital to synthesized, so we still do digital plus the 3D. We have a range of new hires to very senior breast imagers here, and it's sort of hard to meet in the middle, with people becoming, comfortable with reading off of the synthesized. For the last few years, we've said we're going to make the change, but we haven't quite done it yet. But a lot of our, esteemed institutions, in the Northeast and elsewhere, they do it, and their cancer detection rates are adequate and the same. And so that is the goal, right? To take away the digital mammography component and to just do the synthesized and the 3D imaging. But the United States definitely is on the upward trajectory of moving to DBT. So that's great.
Excelente, excelente. Nós esperamos que em breve no Brasil a gente possa contar também com esse método disponível nas redes privadas. Nossa. E também já temos em alguns hospitais, escolas, então esperamos em breve contar com ela mais presente. E parabenizar a apresentação da doutora Stamatia, foi excelente, e nesse contexto de rastreamento cada vez mais personalizado, perguntar para a doutora Stamatia sobre, considerando o descalonamento cada vez maior, especificamente no grupo de pacientes com mutação genética. Será que já temos respaldo e segurança para realmente iniciar a mamografia para todas as mutações a partir dos 40, se elas fizerem ressonância? Porque no contexto do BRCA1 já temos meta-análise mostrando que a mamografia contribui com muito pouco, 3% só de aumento de sensibilidade para a ressonância magnética. Mas para o BRCA2, por exemplo, o aumento é um pouco maior, de 12% em torno de aumento da sensibilidade para a ressonância. Então, a pergunta seria essa: já podemos, com segurança, descalonar a mamografia e iniciar a partir dos 40? Qual é a sua experiência e opinião sobre isso, se elas fizerem ressonância?
So I think you have many good points, and certainly women with genetic mutations that are young, we do want to start them with breast MRI, right? Because they're young, they have very sensitive breast tissue to even minimal radiation. So we don't want to start them at a very young age with mammography. But I do think mammograms are important, and I don't think we should discount them because, although most of the things we'll find with MRI, it's wonderful, there's still high-risk lesions that may not enhance on MRI, and some low-grade DCIS, ductal carcinoma in situ, which we believe is cancer. And so we want to find those, we want to find them before they become invasive, before they turn into a bigger problem. So I do think mammography has a role, and I don't think we should just throw it out, with the water, after the bath. I think we do need to include it. We need to be careful how we include it. Certainly, if you are having a patient come in for a breast MRI yearly, you can decide, to start your mammography screening later. But the problem is, what I find is I like to read things together. I don't like to read the MRI in a vacuum. I do like to look at the other imaging studies, and I like to have that mammogram looking at the architecture of the breast. It may show me very quickly, okay, yeah, that's a lymph node, or that's, a calcified fibroadenoma, different things that if you don't have the MRI, then you're working kind of in isolation a little bit, and you may end up doing more than you need to do. So I think a mammogram to give you really kind of the lay of the land and where you are is very important. So, there are high-risk lesions, those in between lesions, indeterminate things that we may not see with MR, so I find mammography very helpful. The other thing is sometimes it's hard to convince the patients to have a yearly MRI. You know, they'll have it 1 year and they'll say, oh no, it was so uncomfortable. I was, you know, the injection was hot. They couldn't start my IV. I'll have it in a couple years again. And I worry about those patients because they may not come back for MRI. Their insurance may not cover it the following year. They lost their job, they lost their insurance. We do need to keep promoting mammography for patients because even if they have dense breasts, as Dr. Lewin so beautifully mentioned, you know, we're finding all kinds of things with tomosynthesis. And I think we can find things even if there's a lag in their MRI screening. And if you cannot do the MR, then mammogram and ultrasound or contrast enhanced mammography. There's certainly other studies we can do, but I don't want to be critical of mammography because, you know, it not only has been the mainstay of our screening programs, but we have the most data on mammography over the years, and it has been proven to reduce mortality. We're still building our data for MRI. We're certainly not close with ultrasound to build the data. Contrast enhanced is wonderful, but brand new, right? So we need to build the data and we need to defend mammography. And because now if you do a tomosynthesis study with synthetic mammography, like I do on everyone, the radiation is the same, it's minimal. Dr. Lewin's gonna convince her partners to do it too at NYU. It's hard, you know, but we want to do the better mammogram. We don't want to throw out the mammogram because we're going to miss things.
Obrigado.
Posso fazer mais uma pergunta para a doutora Stamatia bem rápida?
Vamos
Doutora
lá.
Stamatia, para as pacientes com mamas densas, a ressonância já é uma realidade nos Estados Unidos para todas as pacientes com mamas densas ou mais para as extremamente densas?
So it's very interesting because some insurances are covering now MRI for women with dense breasts. So in New York State, we have had the law about informing the patient and their doctor about their dense breasts since 2013. So we were doing a lot of breast ultrasound. We still do a lot of screening breast ultrasound for dense breasts. But now patients are coming in requesting MRI and their insurances are covering it. So we are actually doing some breast MRI for dense breast, not every insurance, but some. And I do think if it's covered, we're doing it. They may not want to do it the next year, the same issue, you know, they'll say, oh, I'll do it in a couple of years again. But we are offering it to patients with dense breasts. We also offer it to newly diagnosed breast cancer patients. We offer it to patients with genetic mutations. You know, we offer it to patients that have a lifetime breast cancer risk greater than 20%. So we follow the American Cancer Society guidelines and offer MRI to patients.
Ok, thank you. Giuliano Tosello, doutor Giuliano, por favor, suas considerações.
Obrigado, bom dia. A gente já está em cima da hora, vou ser bem direto e reto. E se os três palestrantes conseguirem responder brevemente a pergunta. No Brasil, a gente não tem acesso, como já foi dito, ao pagamento, né, do rastreamento ou dos exames com tomossíntese. A gente também não tem essa indicação de ressonância, né, para mama densa, como foi dito agora, e gostaria que vocês nos ajudassem. Se vocês entendem que no rastreamento de pacientes com risco habitual e mamas densas ou extremamente densas, a gente deve associar a mamografia à ultrassonografia, ou a gente deve deixar o ultrassom só como complemento ao rastreamento com mamografia.
Me?
Yeah.
Okay. I think even the best mammogram in dense breasts is not perfect. So I think if you can do in dense breasts, the mammogram, tomosynthesis, or digital, whatever you're doing, and an ultrasound, it will be wonderful. Ultrasound, it has a learning curve. And so you need to be experienced with ultrasound. You're going to find many benign things. So you need to build your practice with ultrasound. If you have sonographers, they need to get experience because you're going to end up calling back a lot of things or doing short-term follow-ups. But once you build that first year and then they come back the second year, you'll have all the ultrasounds with the findings already. They're stable. So you'll become maybe your PPV will increase and your recall rate will decrease. So I think breast ultrasound is very helpful. So if you can do both, you should.
Yeah, at NYU, most of our patients with dense breasts get ultrasound and mammograms, and that's just, we do so much screening ultrasound here for that
Henrique,
reason.
você pensa da mesma forma? Henrique?
Eu acho que a tomossíntese deve ser feita em qualquer mamografia, ela é evolução. Eu acho que ela é custo-efetiva, eu acho que tem mais de em torno de 10 estudos mundiais mostrando isso, inclusive o nosso, que está quase sendo publicado, e que esse dinheiro pode ser aplicado em quem realmente precisa, essa economia, para que a gente consiga melhorar. Eu acho que mama densa tem que fazer ressonância magnética. Eu acho que o ultrassom é uma alternativa para quem não tem acesso, mas isso a gente não deve ficar numa posição de conforto para isso. Nós não devemos aceitar isso. Mas a mama densa não precisa fazer a ressonância anual. Eu acho que realmente a questão de custo-efetividade é uma coisa importante, o modelo econômico é importante, então a gente deve fazer a ressonância no intervalo de 2 a 4 anos. Eu acho que uma maneira racional de usar isso é mamografia um ano, ressonância no outro, mamografia no outro ano, ressonância no outro ano. Essa é uma forma racional de usar o recurso. Eu uso isso na minha clínica.
Bom, muito obrigado a todos, foi sensacional, foi um prazer participar dessa mesa, eu tenho certeza que contribuiu muito para todas as pessoas que nos assistiram. Nós vamos começar uma próxima mesa, passar a palavra para o Henrique para ele apresentar os próximos palestrantes.
Obrigado a todos. A próxima mesa vai ser apresentada e moderada e coordenada pelo Dr. Henrique Pasqualetti. Dr. Henrique Pasqualetti é coordenador do CEPEM, CEO do CEPEM e membro da Sociedade de Mastologia. Obrigado a todos. Thank you for all. Bye.
Um abraço, gente.